All right. Good afternoon, everyone, and thank you so much for joining our webinar today. My name is Lenny Green. I am the marketing manager at the BMJ Americas office, and you have tuned into our webinar, Quality Improvement Today, Tomorrow, and in the Future. If you joined this session today, you are probably already aware of quality improvement as a really essential part of your work in healthcare, and most likely you're also familiar with some of its challenges. I hear there are those. Today, you'll hear from two experts with an eye to QI's future, whose decades of combined experience in the field give a view of the industry's past, present, and future. Some quick housekeeping. We'll begin with this expert discussion and then open for audience questions and an exclusive offer for attendees at the end. Meanwhile, I really encourage you to pop any thoughts or questions in the Q&A feature, which you'll see to the right side of your screen. And I think just to kind of test this out, I would love for everyone to tell us where you're tuning in from today. So feel free to pop that in the comments. I'd love to see the spread of attendees. I think it's going to be quite global. Let's see. Excellent. So I see Kieran's welcome message in the audience chat feature. If you're able, drop your location in there. So it could be country, city. And I see Lauren from Chicago. Thanks for joining us, Lauren. We have Khalid from Pakistan. Hello to whomever is in Camden. I'm joining from Jersey City, so not too far. London, Philadelphia, halfway between London and Cambridge. Sounds beautiful. New York City, South Africa, Connecticut, Massachusetts, New York City. Fantastic. So, really glad to have you all here today. And let's jump in. So, it's my pleasure to introduce you to today's quality improvement experts. I'm delighted to be joined today by Dr. Patricia Hinwood, who serves as Executive Vice President and Chief Clinical Officer at Jefferson Health, one of the largest nonprofit health systems in the United States, encompassing 32 hospitals and over 700 sites of care. She's led initiatives in pandemic response, health equity, and quality innovation over diverse populations and geographies. Her work integrates AI powered, data driven decision making with compassionate care to advance scalable, high quality health system performance. Thank you so much, Patricia, for being here today. And the other speaker today is the BMJ's own Dr. Kieran Walsh, who's clinical director here at BMJ. He's the clinical lead of the medical education and clinical decision support products at BMJ. He has a vast amount of experience in online medical education, clinical decision support, face to face delivery of medical education, and both summative and formative assessment. He's a fellow of the Royal College of Physicians of Ireland and adjunct associate professor at Monash University. So, thank you both so much for joining today. And with that, I'm going to kick off. Thank you so much, Dr. Hinwood. So my first question is actually for you. And I want to highlight that your work focuses on an interdisciplinary approach to quality and safety, which is especially crucial. Could you discuss the importance of this approach in today's complex healthcare environment and give us some examples of how it's impacted patient outcomes at Jefferson Health?
Sure. Thank you, Lenny, for the question. And glad to be joining you. Exciting to see the global audience that we have here, as anticipated. Again, speaking from the context of a health system leader in the United States, but have done a lot of global work in the background. And I think the approach that we've been taking, I think, does scale in other settings and work happening in a similar way. I know in other systems. Really, for us here at Jefferson and sort of the approach that we're taking, we really believe in moving from that siloed departmental project approach to a more unified, system-wide collaborative strategy. And that's how we've been driving really big improvements across our system here at Jefferson. We have a program called the OnPoint program, which is our clinical care operating system. And that is really a program that we put together in an effort to really recognize and proactively address the complex socio-technical system and environment that healthcare delivery is happening in today. I think we can all agree that healthcare is increasingly complex, regardless of your practice setting. And we really want to make sure that we're embedding quality and safety further into daily operations and finding ways to facilitate that versus a group that's kind of over here working on quality, that we're really thinking about being an enabler to bring quality into the organization for our teams on the daily basis. One of the keys for us has really been establishing cross-functional teams and how that has been able to drive success, again, in thinking about the many different stakeholders that come together to support our patients and families in delivering outcomes. I think we think about the care delivery setting like an orchestra. The OnPoint team is really helping to kind of conduct how some of those instruments come together in delivering that quality of care. Hopefully something sounding like a symphony would be the goal. One specific example of what we have is something called strategic and tactical action teams. And that's those cross-functional teams that might include things like our physicians, our nurses, pharmacists, informaticists, our teams from analytics, operations. We bring them together to really think about how we can address some of the challenges and opportunities that we see for improvement across the system, and how we can use things like our electronic health record and other processes to really build for sustainability. So we're not just coming up with a quick fix for that year, but thinking about how we sustain changes. We used that during the pandemic. We drove a 15% decrease in CLABSI during the pandemic when many contexts saw that rising. We focused then on sepsis mortality, actually, and we're able to achieve a relative reduction of 20% in our sepsis mortality with that work. Most recently, in the last fiscal year, we focused on our heart failure readmission opportunities, and we're able to decrease our relative 30-day readmissions and also decrease our inpatient mortality with those efforts. So really concrete results that we've seen with the approach of, again, thinking about how we leverage the entire team and make it the work of the organization rather than the work of the quality department per se.
Fantastic. And before we jump into our next question, I want to flag that we are dropping a poll in the audience chat. So if you're an audience member, please feel free to respond. We just kind of want to get a sense of where everyone who's joining us today is in their QI journey at their organization, because as Dr. Hinwood just described, there are a lot of complex moving pieces, a lot of large undertakings. So please let us know. And in the meantime, Dr. Walsh, my next question is for you. So as the clinical director at BMJ, you have a broad perspective on clinical decision making. What are some of the major quality improvement changes that you've witnessed in your decade plus as a QI expert and coach? And what sort of tools can healthcare organizations use to stay ahead of the curve?
Fantastic. Thanks, Linny, and thanks to everybody for joining. Once again, it's great to see an international audience and great to see somebody from Camden in New York. I used to live just up the road from Camden in London, though, different Camden. So I think quality improvement is something that once upon a time we hardly did at all. Then we started to do it and sometimes did it reasonably well and made some gains. But I think now the challenge is to see if we can take it to the next level. And to us at BMJ, that means asking, can we take a more programmatic and long-term approach? In the past, I think people might criticize QI and say it's been a bit of a patch-up. You might improve things in the emergency department by moving people to the wrong ward too quickly. We want to get away from that, a little bit too tactical rather than strategic. I think the question is also, can we make quality improvement sustainable? Some people would say that sometimes quality improvement lasts only as long as the quality improvement project, and then things go back to normal or the way they were. Can we kind of put strategic operations in place so that things cannot revert to where they were? Absolutely, we want quality improvement to be interprofessional. Often it's been too kind of single profession led and maybe just one or two people involved in it. At BMJ, we're delighted to see doctors, nurses, pharmacists, other healthcare professionals using our resources. And lastly, I'd say that in quality improvement in the past, there's this thinking that a magic bullet will fix things. There are the bad news on this webinar. Let's get it out of the way early. There are no magic bullets in quality improvement. We need a systematic approach. We need to do PDSA cycles and improve things slowly and iteratively over time. We're delighted when BMJ best practice is used in quality improvement be talking more about that in a few minutes' time. But once again, we want it to fit into a PDSA cycle alongside lots of other things that healthcare professionals are doing to drive quality improvement. Thank you.
I think that segues really beautifully into my next question, which is about bridging the gap between evidence and practice. So, both of you were describing the downsides of a siloed or sort of patch approach. From your respective experiences, what are the most common barriers to implementing evidence based practices at the point of care? And how can clinicians and healthcare workers, leaders, work together to overcome them? So, I'll kick it off with you, Dr. Walsh.
Thanks, Lenny, again. So I think that it's an age-old problem, the implementation of evidence-based medicine. How can you get the evidence out of the lab and into actual clinical practice to drive improvement? And sometimes it's a very slow pace of change as well, with new initiatives taking years to become routine clinical practice. So our thoughts on BMJ best practice, and I should have said at the start, BMJ best practices are clinical decision support resource, continually updated, evidence-based, actionable content. And in the past few years, my thinking about evidence-based medicine has gone from a clinical epidemiological perspective to the implementation of evidence-based medicine. And you ask people what's important to them. It's number one, can they access the evidence? And sometimes they can't. Can they access it at the point of care, on a mobile, on their own mobile? That's what they want. What if they're offline? What if Wi-Fi in their hospital or their institute isn't reliable in all parts? They want an app. What about integrating it into the electronic healthcare records so they can get an answer quickly? How quickly do they want an evidence-based answer? People will tell us within seconds that they want an answer really quickly, and an answer that will directly address their question. I think one last comment is that sometimes there's been issues with the evidence and the guidance itself, how actionable it is. And we'll probably talk more about this in a second as well, but we have an add-on to BMJ Best Practice, the BMJ Best Practice Comorbidities Manager, to give guidance on the management of patients with multiple conditions. That is 1 in 3 adults in the Western world in hospitals, and amongst older people, it's much higher. So we basically need to improve the evidence and improve the guidance so that they will be more practical and more actionable.
Fantastic. And Dr. Hinwood, I'd love to hear your thoughts on this as well.
Yeah, fully agree with Dr. Walsh's points around access and how critical it is in thinking about how bridging the gap requires that real-time decision support for our teams, as well as I think the focus on the relentless focus that we need to bring towards clinical engagement, and how we can make sure that the information and or those tools are most accessible. I think that's key for us, and that's incumbent upon leaders in healthcare settings to make sure that we're making it easier for our teams to do the right things, that we're providing that access to the tools that they need, and that we're really recognizing and acknowledging the socio-technical system that our teams are practicing, and thinking about how we can support pathways to embed evidence-based medicine and practice more into those pathways. I think one of the things that can be helpful is really looking at things with the lens of human factors engineering. That's one of the approaches that we take, and really making sure that teams that are thinking about bringing those tools together, or how we can support our teams, that we're thinking and understanding not just the work as imagined that we might be planning for, in a QI process, for example, but really understanding the work as done, and thinking about how that work is done is playing out in an organization, so we can think about pathways that are going to support really the adoption of, more rapid adoption of evidence-based medicine, I think is key. For example, at Jefferson, we've embedded some documentation tools actually into Epic and supporting prompting our clinicians with evidence-based assessments. That's been able to then, with some of that build-in, impact over 2 million notes over the last 2 years, in thinking about how we make it easier to bring information to our team members. that heart failure improvement work that I had mentioned. We were able to track the Epic order set, the smart phrase usage that we had created, both by region and by provider. We did a lot of work in celebrating and focusing on some of those top performers, and then recognizing where we had that targeted improvement opportunity as a result of having that information at our fingertips, using predictive analytics to make sure that we're increasing and increasing incorporation of AI coming in how we can kind of flag and support the compliance with evidence-based practice. So I think we're going to see, I know we'll talk about it later in the conversation here, but much more to come as we think about how we can continue to support our team members in having the right tools at their fingertips to be able to both deliver that care and capture the complexity of the patients that they're caring for.
We'll definitely get back to that question about AI because I think that's a fascinating topic unto itself. In the meantime, another poll for our attendees. If you click to the right, there is sort of a bar graph image, and that's where the poll is going to land. So our next question is going live. I would love to hear from attendees about the biggest hurdles that you're encountering at the moment in your QI initiatives. We've touched on some. I think that's the topic for an entire other webinar. There are a lot of them. So would love to hear kind of where you are finding friction in that process. Meantime, Dr. Hinwood, I have another question for you. You have extensive experience in improving care for vulnerable populations. So I want to touch on the intersection of quality improvement and SDOH. How can quality improvement methodologies be specifically tailored to address health equity and reduce care disparities?
Thanks for a great question there, Lenny. Obviously, something that has been a part of the basis for my career and something that we have a big focus here on at Jefferson Health. And I'm glad to be working on leading from the standpoint of being a quality leader for the organization. I think we believe both that quality improvement must be equity driven, and then we also believe that focus on health equity needs to happen from the quality lens. So we do bring that together. That OnPoint platform that I mentioned earlier, we have components of our quality management system, our safety management system, patient and family-centered care, population health, and health equity all together into that same umbrella. And we really see health equity as part of the core of the focus of the quality team moving forward, recognizing that really quality is about ensuring excellent outcomes and experiences for our patients, and that we have to think about that across all of our populations and look at that from the standpoint of demographic and geographic and socioeconomic factors that all may be playing into the outcomes that we're seeing and how we can better understand that. So really using that lens as part of the guiding force that we have in thinking about our quality improvement journey. At Jefferson specifically, we have really focused on health-related social needs screening over the last couple of years. We deployed a tool a little over 2 years ago and then recently published a validation study for that Jefferson health-related social needs screener for the use in both an acute and ambulatory setting. We felt it was important not just to be screening, but really thinking about how we're connecting our patients with resources related to food insecurity or the need for more medically tailored meals, like food as medicine, for example, understanding that difference, transportation needs, housing considerations, utility support, et cetera, that we really see as key drivers in terms of outcomes for our patients. And I think in that period of time since we brought that tool on, we've screened over 1 million people. And I think the screening for this has been like putting a floodlight on some of the hidden barriers that are really there in what's contributing to outcomes for our patients. And then we're now using the information to try to connect our patients to the right resources in a more timely manner to ensure that we can better target those opportunities that we see coming out of the information in that screening to think about how we're supporting outcomes. I think historically there's been a sense from the quality standpoint of kind of the outcomes within our walls, but really that we see that the ultimate outcomes have so many different impacts from the social drivers that we feel the responsibility to think about how we're going to address those better. It's certainly not an easy challenge in terms of sort of the scope and support, but we recognize that readmissions, mortality, infections, et cetera, are connected, so connected to these social drivers that we need to do a better job of recognizing that.
And Dr. Walsh, you have a unique perspective on this around multimorbidities, comorbidities. Can you speak a bit to that component of QI initiatives?
Fantastic. Thanks, Linny. And I have to say, Tricia gave such an impressive answer there. I'm struggling to think of what else I can add, but the good news, I can think of something to add, which is, as you prompted, related to multimorbidity. So we know that multimorbidity is strongly associated with social determinants of health, whether one causes the other or if the other causes the one. They both interplay with each other. There's no question about it. And so that's why we're so keen on providing guidance for management of patients with multiple conditions. This is 1 in 3 adults. And yet, if you look at the research base, the guidelines, the evidence base, you would think that all patients just had single conditions. And they don't. And there can be disease interactions, drug-disease interactions, lots of other types of interactions. One simple example, a patient with COPD, there is a 20% chance that that patient will have diabetes, and treating the COPD can make the diabetes worse. And all too often, we hear of patients admitted to hospital where all the attention goes on the acute condition, maybe the COPD, and the poor diabetologist is called in a few days later and nobody has thought of the diabetes. But with some simple steps that we can guide people towards, that problem can be overcome. And I would say it's a problem initially with people making the transition from medical student to intern to resident doctor. The difference between an expert and a non-expert is the ability to deal with complexity. And we start people off naturally with simple things, but we need to do more to guide them and to help them to manage patients with multiple conditions who are by nature have complex illness. And we need to provide guidance whereby they can do that at the point of care. Just one point I should add to what Trish said, which is that integration into other clinical systems. That's something we need to do better at as well. BMJ best practice, the content is chunked up, semi-structured, tagged, and coded to ICD-10, SNOMED CT, HL7 info button compatible. We're working towards the FARS standard, which in plain English means integration into other systems is now possible, and we've done that with a number of EHR providers, even Epic. Yes, so I think all these things are kind of part of what we can do to improve patient outcomes in patients with multimorbidity or patients who have extra needs because of social determinants of health. Thank you.
Yeah, Dr. Walsh, to your point there, I think the one of the key considerations that we continue to grapple with is really even the shift in what care is happening in what setting, right? We think about the multimorbidity and the complexity of our patients that are admitted to the hospital these days, right? And that's becoming more and more of a challenge, right? We're not often a simple COPD exacerbation that might have been admitted 10 years ago isn't getting admitted. So those patients that are in the hospital are sicker and more complex. And I think more of the opportunities in terms of evidence-based and decision support that we're going to need to continue to bring to our teams as we think about where care is shifting virtually in an ambulatory context, and then the acuity of our patients in the hospital setting is a really key consideration on the path ahead.
Something I'm
Also,
gathering.
well, there was a question in the chat, which I'm glad to respond to if that works. On the million patient screened, what % had needs? So it's variable depending on our location. We're screening both in our primary care and some specialty locations, as well as in our acute care setting, and then variable by hospital. We have a really wide demographic and geographic swath across our health system. On average, we're running around 10% when we look across the board. We've recently been screening in some of our emergency departments, and that number is more like 25% in that setting. And so we're seeing different considerations depending on the hospital and like the nature of the care visit. I'm happy, I'll pop the screener, the paper that we had published if people are interested. It is, validated if people want to use that forward, but at different results. And again, then we're tailoring some of the interventions and resources that we're putting in those settings relative to the needs that we're seeing for that discrete population in that setting.
Fantastic. Well, I know that no one on this call needs convincing of the value of these QI initiatives, but unfortunately, that isn't always the case with the stakeholders that you're communicating with in the healthcare field. So, with the increasing focus on value based care, the ROI, the return on investment of QI initiatives, is really crucial right now. Dr. Walsh, how can tools like BMJ Best Practice help demonstrate the value of QI work? And Dr. Henwood, I'd love to hear how Jefferson Health measures and communicates the impact of these quality and safety programs to these stakeholders, from patients to payers. We'll start with you, Dr. Walsh.
Thanks, Lenny. So we've been delighted to see over the past few years people using BMJ best practice in their quality improvement projects and in their quality improvement reports. There's multiple examples. One group used BMJ best practice to build a care pathway for patients with rib fracture in the emergency department, and they were able to demonstrate improvement. And they also ensured that their measurement tool was evidence-based and that their intervention was evidence-based as well. And also, I hasten to add, they wrote up and they submitted it as a paper to a medical journal, and they got published, which was all the credit to them and to their team and their hospital. There's multiple other examples. Another resident doctor who I know quite well improved fluid management in patients with heart failure, basing the QI project on BMJ best practice. And importantly, he involved patients and also nurses as well as doctors in the QI project, exactly what we wanted to see happen. Another example was that BMJ best practice was used in a QI project to improve turnaround time for rheumatological tests, which I cannot pronounce, at a teaching hospital in London. And that was led by lab staff. One last example, physiotherapists did a QI project for patients with acquired brain injury and shortened time in intensive care. And that resulted in improved care for the patient, but also cost saving. Every day in intensive care that you can avoid, you're saving thousands of pounds. So we're delighted when we see that happening, and our kind of vision is to see if we can align digital clinical decision support with CME CPD, so you can get CME out of it, but also get quality improvement out of it, and sometimes get papers out of it, so that it's a win for the patient, most importantly, but also the doctor and team in the institution get things out of it as well. Cost savings are important, and can be QI in its own, but sometimes it can be QI and cost savings. We've started a new section of BMJ best practice to ensure that inappropriate tests or treatments are avoided. Only inappropriate tests or treatments, I hasten to add. So things like thyroid ultrasound or thyroid antibodies, sometimes they're needed in patients with hypothyroidism, to give a practical example, but they're not always needed, and so if you can avoid doing those unnecessary tests and treatments, you'll save cost of the healthcare system as well as driving quality improvement. Thank you.
Lenny, I think to my aspect of the question and or considerations, I think measurement is obviously fundamental, but also making sure that we are bringing insights to our teams, right? That we have an easy ability for our teams to understand what that measurement is telling us. So the focus on insights from the data as well as transparency in the data is something that has been fundamental for us in helping to drive that prioritized approach to improvement, letting our teams know where we are, where we want to be, why something is in focus. And that data-driven storytelling, I think, is fundamental to impact. And really, I think the messaging and the communication in quality and quality improvement is often under-recognized in terms of the focus on that aspect of the work. Really, the value and the momentum that focused communication can bring and can create in the organization to drive some of the focus that we want to bring to a best practice. For example, For us specifically at Jefferson, we have a clinical quality council where we do review those key performance indicators monthly, and we focus on physician engagement or provider engagement in some of the practices we're looking for adoption, when we look at order set utilization, when we've tried to create an evidence-based pathway for our team, and what the outcome measures are related to those. We've created also something called OnPoint Insights, which is our again, focus on creating insights and our analytics platform that help us bring that prioritized and contextualized view to leaders so that they can access the data, they can see where they're performing, they can see how others are performing in a system of our size. And then that helps us really think about how we can serve as consultants for each other in bringing those opportunities forward. It has helped us, again, the focus and the prioritization in our value-based care performance and our pay-per-performance programs overall. Several of our payers, we've earned our maximum incentives. We've just gotten an award, a quality award from the National Association of ACOs in the United States, and some quality awards from our payers in the Philadelphia region. So we have been, I think, successful in thinking about this approach of how we're driving our teams to think about what matters most, how we can support them in doing the right thing, and how we are very focused in the communication on what those opportunities and the priorities are. One of the things I wanted to highlight that I think has been fundamental to our programs and our success is not just the communication, but really celebrating our teams and kind of bringing up team members that are driving that success. We look for opportunities to celebrate people when they bring event reports that let us know when harm has not reached a patient and where we can create a system fix. That's something we have a great catch program around that we've created, and that has helped really bring in that culture of we want to hear about it, we want to know, we want you to intervene, and then we want to think about fixing the system. We have things like our Mission Moment Awards, where we're really celebrating that service excellence for our team members and lifting up team members that are going above and beyond instead of just an email that might circulate and say, good job. We think about really calling those out. We start our leadership meetings with mission moments or with great catch honorees. We have a great save, which is human vigilance. So when people are just, there might not be an opportunity for a system fix with a great catch, but there's an opportunity to recognize someone that has really gotten in the way and sort of avoided harm from reaching a patient. So all of those things are intentional approaches that we have to communication and thinking about how we want to infuse that quality and safety and experience mindedness into everyone in the organization, from people that are helping us, empty the trash cans and to deliver our nutrition trays. Oftentimes, those are people that are leading to some of these saves and these awards. And I think that that's been important for us in that attentional approach to communication to think about how it's everyone's job to deliver quality in the organization. It's everyone's job to think about patient experience.
That sounds incredibly impactful. What an amazing program. I have one more question for you both, but before I jump into that, we have one last poll question. We will be broaching the subject of the moment, AI, but first I would love to hear what the audience is thinking about how it's going to change quality improvement in the next 5 years or so. So please feel free to chime in that poll. Again, you can click the sort of bar graph iconography on the right hand of your screen. And while you do so, let's jump into a question for the two of you. So AI is the elephant in the room in terms of transformation in quality improvement and quality initiatives. Drs. Hinwood and Walsh, how are you approaching this burgeoning technology, and how would you advise other healthcare organizations and institutions to embrace these early opportunities responsibly? Dr. Hinwood, I'll start with you.
Make sure I can come off mute there. Well, I think I'm a little bullish on the topic, to be honest. From my perspective, I'm both responsible for leading quality in our organization, but also am supporting our AI strategy in terms of thinking about AI integration and thinking about AI and the path forward. So as a result, at Jefferson Health, we're really thinking about a quality-driven AI strategy and integration across the system. And I really see AI having significant potential to really reshape quality improvement moving forward. I think in doing that, we really have to focus at this point in the journey on responsible adoption and really thinking about human-centered adoption. I think that approach, again, recognizing that complex socio-technical system that our teams are working in, how can we think about appropriate integration there are so many tech and AI native companies that have popped up, right, that feel like they have a tech solution, often not recognizing the complexity of really what we're dealing with in the context of healthcare delivery and how we can think about a great idea, but how does that go from a great idea when we think about the tech stack to actually the processes and the people that we're looking to support, whether or not that's our clinicians, our patients and families, depending on who's interacting there. So I really think that human-centeredness is going to be really important for us thinking about adoption into healthcare and how we think about that as a tool to drive quality forward. For us here at Jefferson, we have taken that approach in terms of really messaging a human-centered approach to integration. We have board endorsed goals in equipping all of our leaders in AI training and thinking about them having the appropriate tools for use. And for us, that's very important to make sure that we have people knowing what the rules of the road are and that we want to think about areas we can generate more insights, areas that we can find other approaches to improving outcomes, but also making sure that we're doing that in a safe way, not creating other concerns, risks, or biases. With that human-centered approach, we've also focused on a goal of returning 10 million hours to patient care by 2028. That with an intentional focus on tools that we're bringing in to support our clinicians in reducing their administrative burden and returning more of their time to patient care. And then other goals that we have around the financial transformation that we're looking to drive. We are a safety net system for the eastern half of Pennsylvania here. We unfortunately are based in one of the poorest large cities in the United States, and we're really serving a vulnerable population. And we need to think about ways that we can drive efficiency to continue to really deliver on the mission that we have on improving lives. So thinking about things like integrating ambient. That's a win for us when we think about ambient listening. We're seeing, actually was just this morning looking at some of the crosswalk on data from our patient experience. We see better patient experience. We see our clinicians much happier and feeling less burnout. And we also see that there's an efficiency opportunity in gaining more access for patients when we have more efficient visits and our teams are not spending all of their time after a visit documenting. So those are just a couple of examples, I think, of ways that we see it forward and really think about AI as a partner to augment and elevate our teams and their efforts and our patient experience and not a replacement. I think the insights that we're going to gain from a quality perspective and from a safety perspective, they're going to be hard for us to digest, frankly, right? From a capacity standpoint around we have more information. How do we action that? How do we execute on the insights that we're seeing? So I think that's what we're going to grapple with forward, but I do think it will be transformative for us on the quality path ahead.
Absolutely. And Dr. Walsh, I'd love to hear your thoughts as well.
Thank you very much, Lenny. So I think I'd echo much of what I heard from Trish. I think sometimes people are scared of using AI in the clinical settings, and that's reasonable to be worried about that. But there are other things that you can do with AI, like admin, like ambient listening, etc., which will almost certainly drive efficiencies and drive quality improvement. So maybe it's a good idea to start with things like that. I think we're taking a step-by-step approach, and the first step is almost certainly integration. And so the words I spoke earlier about HL7, info button, FAR standards and integration, etc., they're a step towards being ready for the world of AI. I think that in terms of using AI clinically, people will naturally be concerned for a number of different reasons: hallucinations, error, bias, etc., and ultimately the safety of the results. So we would kind of encourage a cautious approach, and maybe the future will be using AI alongside more traditionally human-created digital clinical decision support. We got to wait and see about that one. But I would encourage people to experiment with AI, try AI, and maybe try it outside of a clinical setting initially, so that you'll learn from the experience, and almost certainly you'll be able to get some things from it. One example is that we do podcasts on BMJ Best Practice. I do the podcasts. I ask largely the standard questions, but then towards the end, I ask tough questions. And I ask questions and I ask an AI, what tough questions should I ask a world-leading professor in subject X for a podcast for physicians? And it comes up with really the toughest questions you can imagine. And I don't ask those questions first. I wait till the end. But it's surprising when the good professors hear them. They kind of smile and they say, gosh, that's interesting. You should have asked me that question. And somehow the AI can come up with that. Also, lastly, it's just a question, you're not asking the AI to give you an answer that you're going to put into practice. It can just help you with questions and with education as well.
So, as predicted, this raised some really interesting audience questions, and I think it would be a great time to move into some of those. So, the first one that we have here, how do we think of governing and testing AI that is in a black box and difficult to objectively test? What are your thoughts on that?
Happy to jump in there, Lenny, since I'm spending a lot of time on that topic. I think as we think about the clinical side in particular, we really need to think about the human in the loop, right, and the accountability frame there. I saw yesterday there's a wonderful strategic forecaster, Amy Webb. If anyone's not familiar with her, she had posted recently, I think earlier this week on LinkedIn, a picture that was from, I think, 1979 or 1970s a management training from IBM that was basically saying a computer can't be held accountable, right? And so I think that's here we are in 2025, and I think that's an important and relevant message when we are thinking almost 50 years later in how we think about AI integration, particularly into the clinical context, right? These will be information, insights, tools, support, partnership. Intelligent partnership is novel for us, but we still have to think about the clinician making the decision at the end of the day in terms of how they're ultimately interpreting. I'm an emergency medicine physician. The EKG has always come with the interpretation at the top. That doesn't mean that was the interpretation that I'm taking in the clinical context for my patients. And I think that's a relevant analogy for how we think about how we need to incorporate, particularly in a disciplined and sort of judicious way in the clinical context as we move forward, knowing that there are issues with hallucinations, that you need to think about the model, and that you cannot just depend blindly on results that are coming out of a GPT in how you're going to move forward, but that you're taking that with the grain of salt that is relevant. For us at Jefferson, we created an AI Center of Excellence in 2022. I co-founded that with our CIO. We have established an AI steering committee that goes across our entire enterprise, actually, which includes a university, the health plan, and the health system. And then we use that in terms of review and governance, thinking about both safety, equity, legal considerations, risk, et cetera, but also making sure that we're focused on strategic alignment. There are a million opportunities, and I could spend all day, every day, with a vendor that's reaching out to me about an AI opportunity, but what are the problems that we're trying to solve? What are the opportunities that we see may be best to apply to gaps that we see in care? From a quality perspective, I think the opportunity to address and close care gaps is going to be, really exciting on the path ahead when we think about AI tools, when we think about agentic voice platforms, et cetera. But at the same time, we have to make sure that we're not taking an answer from a black box. We need to understand the models. We need to understand the inputs that are going into those models. And we need to take that into account in how we're making a clinical decision, in addition to thinking about, where are those opportunities for administrative support to our clinicians, to the healthcare delivery organization in lightening up some of the costs that we have in really delivering care from an administrative standpoint. So just a few thoughts on that.
I think that...
Thanks very much. Sorry, Lenny, shall I come in there just briefly? I think the point about it being a black box is important. With BMJ best practice, it's not a black box, and we make it explicit. The guidelines are coming from Cochrane or relevant meta-analysis or relevant guideline, which we might grade and display in a PICO format, so you can drill down. And I think in AI, to overcome the explicability problem, you need to people will need to be able to drill down. I think testing in a clinical setting is vital. And currently in AI, many AIs have yet to get out of the computer lab and haven't been tested in the clinical setting, and they will need to be. And lastly, Trish, I agree with your point about problems. Somebody once said, and I can't remember who it was, that if I have a problem and I have an hour to solve it, I'll spend 55 minutes thinking about the problem, 5 minutes about the solution. There's something to that, I think. In medicine, we jump in a little bit too quickly with the solution without really thinking things through, really, particularly complex problems. So we run a conference called BMJ Future Health, and we had problem sessions at the conference, and there were we had crowds of people coming into those sessions who wanted to kind of talk properly about problems in healthcare.
There's another question that dovetails really perfectly with this one, I think, which is any advice for successfully promoting responsible adoption of AI within intern and residency programs? So, as two people who are frequently working with new clinicians and trainees, I would love to hear your thoughts on this.
Shall I go first?
Yeah, go for it, Kieran.
Yeah, great. So, I think there is an educational opportunity with AI in terms of using it for direct clinical education, but also in terms of educating people on the use of AI, when it might be appropriate, when you might think about using another resource, which resources to use for what, how to ensure that you do that in a human-centered way, in an ethical way. So, for example, security, education about not putting identifiable patient data into ChatGPT seems obvious, but actually it happens, unfortunately. Energy use of AI is an important topic. AIs use a massive amount of energy in their creation, but also each time we use them. So it's worthwhile thinking, do I actually need to use AI in this case? Or can I just look up on a website or look in a book or ask a colleague? I think in the next few years, more and more people will be thinking about energy use of AI. And one practical tip to reduce it is that if you go to a large language model, you can say, give me a 100-word answer as opposed to a 500-word answer. You'll use an awful lot of energy in doing that. But I guess the core thing is cross-checking and making sure that the AI has, for some reason, come up with the wrong advice, and teaching people how to use it, just as we teach people how to work with nurses and pharmacists and paramedics and other healthcare professionals. We're going to have to teach them how to work with robots.
Kieran, I think that's a great point. It's probably going to be, an emerging topic in health system science curriculum, right, in medical schools, or I think needs to be moving forward. I think, Lenny, to the point around the safe and appropriate use, I think ensuring that I think it's incumbent upon organizations and systems to be thinking about this, right, and to be providing access to safe tools to use, right, that have more of a protected environment, in recognizing, to Kieran's point, that people are not thinking as much as we would like from a privacy perspective. And we need to make sure that we're recognizing what's happening, right, in our socio-technical care environments, and that then we're thinking about how are we going to address that. We do have a enterprise kind of access to an AI tool so that we have people directed and going that way. Again, why we've been intentional around the board endorsed goal around leader training. We want people to be using these in the open, right, and not unsafe tools in the background. So I think it's important to recognize that this is okay. This is something that's has the ability to augment the work that you're doing, and or bring further information and insights to your fingertips faster when you're thinking about care delivery, but that we need to make sure that that's happening in a safe and appropriate way. And that's something that I think organizations really need to be focused on tool access, as well as the training on what's safe and appropriate use and what's not okay from the standpoint of the organization.
I'm struck from this conversation by the vast scope of quality improvement projects. So they can range in terms of subject matter and, end goals and things. If you were advising a new clinician or trainee hoping to embark on a QI project, how would you direct them to kind of narrow down the scope of their project or choose something that has potential impact? Do you have any thoughts on that?
Kieran, you want to take that?
Yeah, I'm happy to go first. I would say, broadly, don't rush in. I think too often in the past, people kind of rush in, they start the QI project without really thinking it through properly. I would say to them, talk to your boss, talk to your team members, find out what the problems are, first of all, that you think need to improve. And QI initiatives work best when they're a mixture of bottom up as well as top down, and then think about what tangible things you can do to improve things, and also as a resident doctor, what realistic things you can do. And you'll have to do them as part of a team, because you're not going to be able to, as a resident doctor, you're not going to be able to set up new clinics or open new wards and things like that. So you're going to have to think systematically and about the entire system, ideally. One last tip is that I would say also to a junior doctor, plan it from the start, get approval for it, write a protocol, because at the end, you should be able to write up a quality improvement report, submit it to a journal, and get a publication out of it. And I think many people who do QI don't get sufficient credit for their work, and all the credit goes to biomedical research barons. We've got no issues with biomedical research barons. Most of them all of them are really nice, we think, at BMJ, but we want to balance things so that people who do practical work can get published as well. We've got a journal, BMJ Open Quality, that can publish work of this sort. And also at BMJ, we're happy to give guidance to people on how to write up your work so it will get published, and how to plan your work from the start using SQUAR guidelines, etc., so that it will get published. Sorry, it's a long answer.
I think it's a great answer, and it's a great point that I'll echo the points that Dr. Walsh is making now, and then to earlier questions. I think the consideration of really falling in love with the problem and understanding the system in which that effort, initiative, focus, disease state, whatever it may be, is functioning in. I think that there is often a consideration to rush in, but if you don't understand the entire sort of healthcare ecosystem that you're thinking about, both in terms of what's the challenge, what are the interactions between our clinicians and the system, between our patients and our clinicians, between our patients and their families, our patients and their environments, the efforts that we can think about from improvement oftentimes won't take hold and or won't sustain. So I think really thinking about building for sustainability, thinking again about those cross-functional teams so that the work that you're doing not only has more team members to ensure that it sustains if you're a clinician or a trainee and you're pulled in other directions, but that you really have the perspective if you're thinking about medication adherence, that you're talking with your pharmacy team and the cost of meds, you're talking with your case management team, your care coordinating teams, that you understand all of these pieces that might be the drivers and thinking about how you're going to approach the improvement. So I think really thinking about having that right team and that broad perspective before you're zooming in on a specific problem that you're looking to solve. And love Kieran's points around the publication. I think that there needs to be more work in the quality improvement space from the standpoint of creating the academic basis, right, for the work that's happening, sharing the knowledge, sharing the approach. I think we are often struggling when we're setting priorities and we know other systems have done it and we know the results, but it's very hard when there's nothing to reference on the work that's happened. So I think it's a great point that we need to continue to think about that learning organization approach, even if you're not in an academic setting, that you can contribute with a problem that you might have solved and that other people want to think about how they can lift that up to work for their system or their population.
Thanks, Trish. I would add that when you share, you prevent something called reinvention of the wheel. So often people run a QI project, invent something from scratch when somebody down the road has done something very similar and they can build on their work. But we can only get there when we share what we've done through getting published. And it's partly down to journals, so for us to publish that work as well.
That almost connects to the point we were making, or that the two of you made, about communicating ROI. So communicating what's been done in terms of quality in the past so that no one is inclined to reinvent the wheel. I love that phrase, falling in love with the problem. That's beautiful. So I don't see any more questions in the Q&A. If you have questions following this event, please do reach out to us because we'd be happy to answer those. I want to thank you, Dr. Hinwood and Dr. Walsh, so much for leading this edifying conversation. I want to thank all the attendees. I hope this has given you some food for thought and some action items that will streamline your next QI initiative. On that note, I wanted to mention that as an exclusive for webinar attendees, we are offering a free custom demo of BMJ Best Practice. It's a tool that you heard a little bit about in this conversation. It's a clinical decision support tool, and it's fantastic for powering QI initiatives, specifically if you're hoping to enhance things like patient safety, manage comorbidities, reduce costs, empower multidisciplinary teams, things of that sort. So to take advantage, you can directly email Dr. Comfort King, who is BMJ's clinical engagement lead. Her email is listed here on the screen. Please do reach out, and you'll hear from us again via email if you registered for this webinar with the same information. So thank you so much for coming. Thank you, Dr. Walsh. Thank you, Dr. Hinwood, and have a great rest of your afternoon or evening.
Thanks for having me. Enjoy the conversation. Take care, everybody.
Thank you.